Welcome again, everyone. This is the Is It ADHD webinar brought to you by the REACH Institute. We're very happy to have you all here with us tonight. I'm Lisa Hunter Romanelli. I'm the CEO of REACH and a clinical psychologist. And I'm happy to have with me three great presenters whom I will introduce in a moment. But before I do that, I just want to tell you a little bit about tonight's webinar and the format that we'll be following. So as I mentioned, the title of the webinar is It ADHD? And the purpose is to talk about some of the challenges that are associated with diagnosing ADHD and some of the co-occurring conditions that may show up with ADHD and make it confusing to know if a child has ADHD or something else. So the format of our webinar today is we will have, I will introduce our speakers, and then each of them will give some brief introductory remarks, as well as tell you a little bit more about themselves and their background. After those introductory remarks, we will open it up to questions from all of you. So we welcome and encourage your questions. If a question comes up as one of our presenters is presenting, feel free to put it in the chat, and we will be keeping track of those questions and address them and answer them during the question and answer period of the webinar. One thing to keep in mind with your questions is that none of our panelists can provide specific medical advice for your child because they don't know your children. But they can answer general questions. So please keep that in mind when you pose your questions. Before I introduce the panelists, I want to invite all of you to type into the chat where you are from, because we'd love to know, and also what hat you're wearing as you're listening to the webinar tonight. Are you listening as a parent, as a provider, as a teacher? We'd just like to get a little sense of the audience. So go ahead and type that into the chat. And now to the introduction. So as I said, we have three great presenters here tonight. Annie Lane Rogers is the general manager of ADDitude magazine. Jennifer Erickson is a health psychologist and a licensed professional counselor. She is also a member of the Anxiety and Depression Association of America. And then Dr. Rachel Peterson Wynn is a REACH faculty member and also works at the Mayo Clinic. So I will now turn it over to Annie to start with her introductory remarks and also to give a little more information about herself. Annie?
Great, thank you so much for the introduction and for inviting me to join this conversation tonight. I'm very excited to be a part of it, and on behalf of ADDitude, I would like to wish everyone a happy ADHD Awareness Month. My tenure with ADDitude actually began about 16 years ago, and I would say that our understanding of ADHD has really evolved in that time, from primarily focusing on ADHD and its co-occurrence at the early days with learning disorders. And ADDitude as a magazine was focused primarily on that intersection of attention deficit disorder and in children, primarily learning differences ranging from dyslexia and dyscalculia to even dyspraxia and dysgraphia. And what we have found, especially over, I would say, the last 4 or 5 years, is a greater recognition of just how comorbidities are the rule and not the exception. And so this ADHD Awareness Month, we actually endeavored to make that the focus of our our education initiatives for ADDitude. And we created this campaign, ADHD Loves Company, where we focused on exactly that, just how does ADHD overlap with these other conditions. And we, I'd say this conversation for us really got going last year when Dr. Teresa Cerulli hosted a webinar for us with the title of which was Complex ADHD. And I pulled a quote from her: "The presence of co-occurring conditions almost always muddles the diagnosis, treatment, and prognosis of ADHD. ADHD and comorbidities may also influence the presentation and severity of one another, which can complicate the detection and treatment of symptoms and impair overall quality of life." I think that's just such a succinct quote there, really communicating why we're here. And we do know that, as she said here, ADHD exists alone only about a quarter of the time. We actually have found that about 80% of adults and 60% of children have ADHD plus something else or some things else. And we've seen this recognition, that in 2019, the AAP recommended comorbid evaluation for children. In 2020, the Society for Developmental and Behavioral Pediatrics recommended that clinicians develop multimodal treatment plans. And so this year, we decided to do an editorial survey at ADDitude to get a better sense of just how this landscape was shifting, what comorbid conditions were really the most common. Now, this is admittedly an editorial survey. This was not a piece of scientific research, but we did survey about 1,100 ADDitude readers about their children. And we learned that we were expecting to see maybe the greatest prevalence being what we had traditionally thought, namely dyslexia, oppositional defiant disorder, and anxiety. But what we saw was anxiety off the charts. And you can see that here, that about 2/3 of the parents that we surveyed said that their children have been diagnosed. These are diagnoses. Now, these are self-reported. Again, this is an editorial survey, but that really got us reeling. And the overall survey was about mental health, and only less than 6% of caregivers of adolescents, so age 12 and up, I believe that was, rated their children's mental health as very good. It really painted kind of a bleak portrait for us. And when we dug in, we saw that adolescent females in particular, 77% had a comorbidity of anxiety reported in our survey. And just on the heels of this, the AAP released a new set of guidelines just earlier this month, recommending that all children age 8+ be screened for anxiety, depression, and suicide risk. Now I'm gonna leave a lot of the diagnoses, intricacies to the MDs here. I am not an MD, but I just wanted to touch on how the screening is really not straightforward for a lot of reasons that our readers reported to us. For one, the presentations, we know that ADHD is a heterogeneous presentation. It doesn't look the same in any two people. And combine that with anxiety, and it's going to look different with every patient that is evaluated. And here we can see that the sources of anxiety today are so diverse, ranging from a very high level of anxiety about school. COVID-19 is there, all the way down to access to healthcare. There's just such a range of concerns that a lot of adolescents, quite frankly, concerns that we didn't have to face as children, certainly COVID-19. But modern worries, and what we find is that untreated or undetected and untreated ADHD can actually exacerbate, and in some cases even cause, the anxiety as a secondary condition. and which further complicates the diagnosis. And I've got a few quotes here that are, part of our ADHD awareness. But of course, if a child has undiagnosed ADHD, they're receiving a lot of negative feedback in their everyday lives. And that can really harm their self-esteem, which can cause feelings of anxiety and depression. Also, social struggles often go hand in hand with ADHD, and sort of missed opportunities to socialize with friends and develop those skills can cause social anxiety as a secondary condition. And as Dr. Ramsey says here, ADHD is sort of tailor-made for anxiety, right? Because the things that should be straightforward are problematic. So I wanted to just read a few quotes from ADDitude readers, about their children, to just give a sense of why this matters so much. It really is critical that we evaluate patients and children in particular for all the comorbidities that we see here, because it can make an enormous difference in their lives throughout the lifespan. So, here's a parent, this is an 11-year-old, depression is a ruthless hijacker, and the ADHD is just one more factor that can make him hate himself when he's already depressed. My child has an IQ level of superior, but school can frustrate him to no end because the last thing he wants to do is sit and read. He's smart enough to notice that other kids finish exams before he does, completing the work before he does. You can see it's just so complex and intermingled in each child. And I'll skip to everyone can read these, but I'll skip to the last one here, which is, in the interest of time, a 12-year-old. My son's behavior worsened during COVID. And I should mention, we did ask our readers, those whose children have anxiety, 2/3 of them said that anxiety worsened during COVID. He became visibly depressed, stopped making an effort in school, even when he knew the answers, didn't want to maintain any friendships, and became frightened of things that were previously common to him, like his bedroom at night. Getting a neuropsych exam that highlighted his anxiety and resulted in new medication changed the entire picture. So that is the end of my my introduction here. And so I can hand over the microphone.
Thank you, Annie. That was a great presentation, really interesting survey, and I'm sure folks will have questions about it during our Q&A period. I'm going to turn things over to Dr. Rachel Peterson-Wynn. And Rachel, do you want to introduce yourself and share with us a little bit about the diagnosis process?
Yeah, so I'm Dr. Rachel Peterson-Wynn. I am a general pediatrician, and I've been working with the REACH Institute now for a little over 10 years, and teaching and learning all the time as I work with REACH. I am a general pediatrician at the Mayo Clinic in Rochester, Minnesota. I've been there for 15 years, and there I do a general outpatient practice 5 half days a week, and other days of the week I do an ADHD referral clinic. So in that work, I get a lot of opportunity to meet kids and families who are wondering about a potential diagnosis of ADHD. So with that background, I really am delighted to have time to talk with you a little bit about the diagnostic process. And I could see in the chat that a lot of the people that are joining us today are in medical practice, so a lot of family medicine and pediatrics, also some social work and some parents. So it's really great to have all of you with us. When I think about the question, is it ADHD? And I think about all the other things we have to consider when we're asking ourselves that question. It can even feel overwhelming at times. And what I tell parents and kids and other providers on the team when I'm meeting with people about the potential diagnosis is that right now, we do not have a blood test, we do not have an x-ray or one thing that can tell me, yes, this is ADHD, or no, it's not ADHD. So what we do is gather a lot of information. We try to gather as much information as we can. And so we do that by using, in our primary care setting and in my referral setting, we do that using standardized questionnaires. So we use the Vanderbilt, and there are other questionnaires that are validated and can be used for that. That helps me so much because it allows me some communication with the teacher to get their direct feedback as far as what they're noticing in the classroom, and then have parents fill them out, and it gives us an objective way to look at some of what they've been noticing. Now, when we're making the diagnosis of ADHD, if the questionnaire could tell us everything, it would be easy. We wouldn't even need a whole webinar tonight. We would just know, like, you just fill out the questionnaire and then we know yes or no, ADHD. But there's more to it. So the questionnaire helps us see how many symptoms are present. Are people noticing these symptoms in more than one setting? And then it also can help us see, are the symptoms causing impairment, or are the symptoms getting in the way of things and making it difficult for the child to function? And then we have to, though, where the real work comes in is then figuring out, could these symptoms be caused by any other disorder, or could there be any other cause for these symptoms? And that, for me, I figured out at some point while I was doing these evaluations, that's the hard part. The rest, is not as difficult as this last part of figuring out, could the symptoms be caused by another disorder? In the medical setting, we need to think about things like a hearing problem, or things like not getting enough sleep, making it hard to stay focused and pay attention during the day, or hard to hold back impulses. But then we have to think of other things too that I felt like I had less training to figure out, like, could there be a learning disorder? Is there potentially an anxiety disorder? Or is there depression? Could it be autism? And so the work that I get to do became much more clear in my mind. And the work that I'm doing also became more satisfying when I really took time to understand, how do I make sure I'm identifying those other potential causes? And how do I communicate to families about what else might be happening? I think as that became more clear in my mind, one thing that really, really helped is other standardized questionnaires. So I mentioned the Vanderbilt, but then for anxiety, especially having a standardized way to evaluate for that, I use the SCARED questionnaire. And then for older kids with depression, I use the PHQ-9M, which is modified for adolescents. And then having a way to look for substance use disorder, so using the CRAFT. But then even if somebody could fill out all those questionnaires, it's really important that I get time to spend with the child or the adolescent in the room, and I get to talk with them and find out really what are some really great things about them, and what are things also that are a challenge for them, and places where they really need some help. So as I talk with families and we start to understand, is it ADHD? Is it ADHD plus? As Annie said, sometimes even if I figure out they have anxiety, I still have to figure out, do they also have ADHD? Or if we know they have ADHD, we have to think, could they also have anxiety? And then the real challenges come in of understanding which disorder is causing more difficulty for them at this point, which disorder is causing, more impairment, making it hard for them to get through the day. And then that gives us an idea where to focus as we start with things like treatment. When I think of patients that I see, I certainly have many examples of patients who came to me knowing potentially they have autism, and maybe they're like Annie's. In fact, I have a patient in my clinic who is a patient who is 17 and has a known diagnosis of autism with superior IQ, and also has ADHD and has more recently developed depression. So as he comes in, sometimes it's a diagnostic dilemma and question. Sometimes it's a question of where's the balance of your symptoms right now, and where do we need to focus our treatment? So, we have this list of criteria for ADHD. How many symptoms are there? Are they occurring in more than one setting? Are they causing impairment? Did they start before age 12, or before age 12? And then could it be caused by any other disorder? But as we determine they may have more than one disorder, that's where we come in with which is causing the most impairment, where can we help them the most? So I look forward to your questions as we go throughout our time together. But before that, I'll turn it over to Lisa so we can hear from Jennifer.
Thank you, Rachel. Lots of great information. So last but not least is Jennifer Erickson. And Jennifer is going to be talking about some of the additional factors, social, emotional, environmental factors that influence a diagnosis of ADHD. So Jennifer, I'll hand things over to you.
Great, thank you. And it's such a pleasure to be here tonight. So just to give you a little introduction, I am a health psychologist and I'm a licensed professional counselor in the state of Virginia, Florida, and Utah. And so I work with people all over, adults and children. And interestingly enough, as I listen to everybody, I, almost different from Rachel, I come into this backwards. I'm originally an anxiety therapist. I loved, which sounds weird, I loved anxiety and loved being able to help people work through it. But going through my training and all my initial experience, I also enjoyed working in substance recovery and family practice and marriage couples therapy. And then I actually worked in eating disorders. And while I specialized in different areas to kind of build all my experience, because as Rachel mentioned, it is trying to figure out, at the heart of what diagnosis is having the most effect on people. As a psychologist and as a therapist, the more experience you have in different specialties, the more you can draw stuff out. Always working with anxiety, no matter what field or what specialty I was in. But interestingly enough, after a couple of years, what I really started noticing is a correlation with ADHD. And that actually is what led me down my ADHD path, is because people would either come to me, whether it was due to an eating disorder, substance issue, or relationship issues, whether it was friendship issues in middle school. Again, in the eating disorder clinic, we had both very young children and adults. And interestingly, again, enough, we had to either send people out for testing, or somehow that would come up that they would say they've already been diagnosed. And some even misunderstood and would say, well, I outgrew that, so it's not an issue now. And so that's actually, again, what started me really narrowing my focus and looking more at ADHD, because I found there isn't always enough resources therapeutically, especially, as a therapist, where somebody is well-rounded, and again, there's a lot of therapists that we trying to get well-rounded, but that actually really understand autism spectrum and ADHD and cognitive processing issues, executive function issues, and kind of that whole realm. And that's actually what led me down my path. And I really enjoy working with it now. So I was really interested in sharing this topic, and let me share my slide here. And so that is what I'm going to talk about, kind of adding to what Annie and Rachel shared, is the additional factors that could influence a diagnosis that people really do want to look at. And here we go. There we go. That's better. All right. So one of the very first areas I'm going to talk about is the social factors that may influence the area of ADHD, or should prompt consideration for evaluation or diagnosis. So when you look at especially children, cognitively, their prefrontal lobe isn't fully developed. And so children look at the world very differently than adults do. They're processing through their amygdala, they're processing through their temporal lobes, they're processing through a lot of different parts of their brain, but not with a lot of constructive cognitive thought because they just haven't finished developing. And so what we end up seeing is social immaturity. They can't necessarily read the social cues. They might appear bossy or controlling. They have an explosive personality. They're trying to manage. They have poor social skills. And so when we see kids, and yes, we'll say, well, this is a 5-year-old or this is an 8-year-old, they're immature. Yeah, but when we look at lifespan development, are they immature in the right ways or kind of skewed to one side or another? And so it really is looking at social immaturity. What goes along with that then is actually peer rejection. 50 to 60% of kids with ADHD are rejected by their peers and bullied in elementary school. So this starts very young. And what happens, especially when we bring up something like personality, which comes in along with other stuff, introvertedness. So a lot of times what we think is somebody who's, just not getting along, not connecting, and we mistake that for introvertedness. What happens is we don't understand maybe they're being rejected by their peers. They're not able to, and they don't understand why their peers. But believe it or not, even at a young age, children can sense what doesn't feel right. Somebody's interrupting when the group of people the group of kids stand around talk, and somebody's always interrupting, or somebody's fading off and drifting away in conversation. Somebody's talking over the other. Kids can sense that. So even at a young age, kids understand social cues. And so when somebody is bypassing social cues, when somebody's not listening, kids will get rejected again. And this starts even in elementary school. And then school bullying then can actually happen again, even at the elementary level, because they become the person, a child might become teacher's pet. They always need help. They always have to ask questions. Maybe they're always bouncing around and distracting the teacher. Maybe they're defiant or can't, again, those social cues of self-control. And so the social factors, when we look at kids, we should look at those overall social factors to see, again, while yes, kids are immature, but are they immature in the right way versus, again, a little more left or a little more right or something? How are their social relationships? And again, we don't want to be fooled by personality, by introvertedness, to think, well, maybe they're just so shy. The reality is, are they just even more shy because of what they're going through? So we really do want to look at the social factors of what kids are going through. Next is the emotional factors. Again, executive function difficulties. Kids, even at a young age, have issues with impulse control. And again, we know there's 5, 7, 8, 10, 12-year-olds. And we know that, again, prefrontal cortex isn't completely developed. They're not going to think completely rationally, but executive function skills start at a young age. One of the examples that a professor that I follow actually shared is, if you imagine 2 kids, siblings, and they're sitting and they're playing, and one of them can hear mom coming down the hallway and knows, if I hit my sibling right now, they're going to hit me back, and I can time it so mom sees my sibling hit me so they get in trouble. Kids really can plan and strategize and organize their thoughts at a very young age. So when kids are really struggling with executive function difficulties and can't do some of those basic sibling fight things, we should notice that. And then, as everybody's talked about already, anxiety and depression. So one of the questions is sometimes, which came first, the chicken or the egg? A lot of times kids will present with anxiousness. But is it potentially because there's ADHD behind the scenes? The issues with working memory, being able to process thoughts in the now. Does their teacher call on them and all of a sudden they get so nervous, not because they're really introverted or shy, but simply because they can't gather their thoughts? And when somebody is being told, and this really, we see it in middle school and high school, hey, you know that you can do this work, you just need to turn everything in. Or, hey, last week you did really good, why aren't you doing good this week? And this could be teachers, this could be parents accidentally, again, not realizing what they're doing is putting on a pressure to the child, but not realizing the child isn't not trying, they're just not accomplishing. And there's a difference between not trying and not accomplishing. And when a child, again, at a very young age, starts to think, well, I'm going to mess up, I'm going to fail, I'm going to upset somebody, they start to constantly just in that amygdala, that fight or flight, they start just getting nervous. And that's where we see a lot of anxiety, is that constant worry about what am I going to do wrong? And then when their emotions, that fear starts getting bigger, sometimes then they also switch to depression. And so,
Jennifer, I'm just going to give you a friendly time update. You have about 1 minute to get through your next slide.
Sounds good. So then depression will also then be a factor because, again, they're getting sad. They can't process their feelings. So the environmental factors really, and this is a lot of things where even though kids are young, they tend to be adaptable. And when kids have a negative response, something traumatic, obviously COVID affected a lot of people, but it could simply be something that we sold our house and moved to another house. I switched from elementary school to middle school or middle school to high school. So something like that can actually, parents will focus on this event and not, again, see that kids are processing difficulty. Homeschooling can actually fool people because homeschooling is so adaptable that it doesn't always have a rigor that forces kids to meet deadlines. Stereotypes also, and female stereotypes also, again, that stereotype that children don't understand and that they don't get believed. And that's one of the stereotypes that kids talk about is because I was young, nobody believed me. And then females, a lot of stereotypes with females are if they're not doing well, it's because it's emotion-based. And females tend to get ignored when it is potentially cognitive-based. And so the stereotypes will get missed, and we should actually look at those and kind of bypass and see if there's and it's something influencing the diagnosis, rather just assuming, well, if they're a girl and they're crying, that just means they're depressed or anxious or all the other diagnoses that are out there. And so those are the three factors that people really should look in considering getting evaluation and diagnosis. So I'll let you take it over from there.
Thank you, Jennifer. So we're now entering our Q&A period. I'm going to get us started with some few questions to each of the panelists. And then I know that some questions have already come into the chat, so we'll make sure to get to those as well. So first off is a question for you, Annie. And I was wondering if you could share a little bit about how common is bullying for children and adolescents with ADHD. Jennifer just mentioned bullying as an issue. Can you talk a little bit about that?
Yes, and actually our data matches exactly what Jennifer said. We found in our survey that 61% of caregivers said that their child had experienced bullying, and that's just bullying at school, actually. And that's sort of more than double what a neurotypical child would experience. In addition to that, about 30% experience some kind of bullying on social media, 26% on text messages. And so one of the really tricky things here is that about 2/3 of the bullying happens with, so-called friends or classmates, but more than 1/4 of parents said that their child had been bullied by a teacher or another authority figure. And it's a huge problem, exactly in, as Jennifer was saying, misunderstood signs and symptoms of ADHD. And, yes, we find that it's more prevalent in girls because their symptoms are misunderstood. There are still so many lingering stereotypes about ADHD as a young boy's disorder. We know that is not true, and we know that girls are being underserved. And one of the ways that shows up is, bullying from authority figures. And so when that happens, the child's less likely to report it, right? I mean, they don't always feel comfortable going to a parent. They're embarrassed. Maybe they feel shame, which is very common. And so we find that it really is a big problem. And I would just underscore that. I know there was a question in the chat, maybe we'll get to it, that, part of this, as Jennifer was saying, is that emotional dysregulation is such a core facet of ADHD. It's not in the DSM, it's not part of the diagnosis, but one of our contributors, Dr. Russell Barkley, strongly believes that it should be. And so if you see, like, if a child may be facing social ramifications because exactly like their classmate is hitting them before the teacher walks in the room, right? And they've got this impulsivity plus the emotional dysregulation, they're going to respond. They're going to get in trouble for that. So I just wanted to bring that up again as a really important component here that is not necessarily in our diagnostic criteria.
Yeah, no, that's an important point. Thank you. And Rachel, if this question just came in, what is the youngest age you have seen a child with ADHD, and how was the diagnosis made? Oops, you're on mute, Rachel.
Thank you. Yeah, I have a really recent experience with a patient in my practice that in her third, she's like 3 years old, not yet 4, and I think she's now 3 years, 7 months of age. She is the youngest. She had multiple evaluations, so not just by me, but by psychology and psychiatry and multiple evaluations. And so that's the youngest age I have seen. In my experience as a primary care provider, even with additional expertise, I will make the diagnosis in kids that are 5 years of age if it's clear that other developmental factors have been well evaluated and hearing and vision are normal, and parenting techniques have been reviewed and are really being followed. So, when I was initially out of my training, really, we didn't make the diagnosis under age 6. So this has been a shift for me. But my youngest is around the age of 3.5, but that's not typical for me.
Yeah, no, it's hard with the little ones to know. Is it sort of typical, 3-year-old behavior, or is it something more?
Yeah, and I feel like the younger the age, the harder it really is to know, well, what does anxiety look like at that age? How do they show with explosive behaviors? Is it something that is related to them feeling very anxious and they can't communicate? Is it impulsive and related to ADHD? Or communication difficulties, and has autism already been, ruled out? So there's a lot to think about. The younger they are, and then for us, as they get to the teenage years, so for adults, it's a whole nother topic, but for us, as they get to those teenage years, I just know in the clinic, the referral clinic, it's going to take me a lot longer with a teenager than many younger ages. It's more time evaluating for comorbidities and then thinking about or having time to talk with them independently, parents in and out. And so.
Yeah, you're highlighting that it takes a lot to come to the diagnosis, a lot of
Yes.
information gathering. Yeah. Jennifer, a question for you. You mentioned in your remarks about how anxiety and depression can sometimes muddle that diagnosis of ADHD. And the question is is there, in your experience, is there a way to know whether the anxiety is just anxiety, or is it anxiety that is influenced by ADHD?
And that's a great question. One of the factors that I found is when a child introduces the idea that they're anxious or depressed, sometimes we jump to start trying to solve that, but we don't ask why, or we also don't ask, describe what you mean by anxiety, because again, kids don't have a full vocabulary. And so what we need to do is actually ask them, what do you mean? Can you explain what you're calling anxiety? Can you explain what you're calling depression? Because some of what they're trying to explain is, I'm sad because I can't focus. And really trying to separate the two is one of the core things, is the ability to focus or process in the now. And so are they reacting to that? Or are they truly sad? I'm lonely, we just moved. Is there another factor? And so that's really actually stepping back and ask the kid to describe why they are sad or why they are anxious, and letting them describe it, so you can really think about the true cause and effect.
Great, thank you. We have another question, and the question is, how can we differentiate esteem, ADHD, and social anxiety when a child is becoming aggressive towards others? I don't know, Rachel, if you want to take a stab at that one.
Yeah. So it sounds like, I think the first thing you said was esteem, ADHD, or anxiety.
Uh-huh.
Yeah, with aggressive behaviors. And so, again, it's going to take some detective work. There's not going to be one questionnaire. There's not going to be just one brief interview with a child. It's going to be really helpful to know, in the settings where the behavior is occurring, what's happening before the behavior starts, and how does the child respond to things that are happening in the environment. We do spend time trying to figure out, is anyone observing a time that it seems like the behaviors are something other than impulsive? Are the behaviors being kind of planned or thought through with the intention to hurt someone or get someone in trouble? But if they clearly are always looking like impulsive behaviors, then that's I'm definitely thinking more about ADHD or anxiety. For esteem, it's harder for me to say, I assume by that they mean self-esteem and kind of feeling badly about themselves. And that not necessarily being a diagnosis, but just kind of being present in either of those settings is pretty likely. And then I think knowing how are other things impacted in the child's life. So how are things like appetite and sleep and friendships? What have things been like as far as separation from the parent for things like going to sleep on their own? And so depending on the age of the child, that information may be really helpful for me to point a little more towards anxiety versus ADHD. But then I'll always put a plug in again for the questionnaires. So they're going to be part of that evaluation. And using the SCARED for me has just been so illuminating to know, how worried should I be about anxiety? How much more time should we spend talking about anxiety as we go through the work of doing the diagnosis?
Great. Yeah, and since you just mentioned rating scales, we had a question about what rating scales you use for older teens. Hopefully, the person who asked this question said, ones that allow the teens to describe themselves. So, do you want to, Rachel or Jennifer, briefly share any specific questionnaires? I mean, you mentioned the SCARED already, which is the screen for anxiety and related emotional disorders. Any other, and that's mainly for anxiety, but Rachel or Jennifer, any others that you would recommend?
Oh, go ahead. Did you?
Oh,
I was waiting to see what Jennifer wanted to say, but I will say for adolescents, I don't feel like I have a great questionnaire that lets them really express a lot about themselves. We use the PHQ-9M. I will give the scared if I'm really needing to sort out a specific subtype of anxiety. Sometimes I use the GAD-7, but that really needs to be followed up by a lot of questions in the clinical interview to sort that out. And then the craft is really helpful for substance use. And I know there are other questionnaires available. I think a lot of clinics for adolescents.
I'm sorry to interrupt, but I just got a clarification for that question. I think they're specifically asking for ADHD.
Oh, yeah. Sure. Yeah, so the Vanderbilt is not validated above age 12. I still use it pretty frequently to just get a feel for the number of symptoms and the degree of impairment and concern for co-occurring conditions. And then really it's about for me, it's about clinical interview and getting to know them that way as opposed to a specific questionnaire.
Yeah, depending on the age group, I've used Brown's or the Connors. But they actually, like Rachel said, the assessments help, but it's actually the clinical interview that I get more of. And the assessment that I use is really more to validate the interview. I think the interview is the more powerful thing because we're looking for, at the same time that we're trying to rule in something, we are trying to rule out. So you're constantly juggling their comments. And so the assessments are nice, but there are many of them. So it just depends on which is sometimes more convenient to your office or your setting.
Yeah, that's a very good point. Let's see. Next question. When a grade school child presents with symptoms of ADHD, anxiety, and sleep difficulties, where do you recommend starting? Presuming that there wasn't one that clearly presented first and family history is positive for ADHD and anxiety. So I guess the question is, where do you start when there are multiple things going on?
I'm happy. Go ahead.
Go ahead, Rachel.
I'm happy to give from my medical perspective. So sleep is just so important. And if children are not sleeping well, determining, how many of these symptoms are anxiety or ADHD can be really difficult. So, doing all the things we usually do to try to help with sleep is where I'll want to start. And then it can be really hard to tell what's the most impairing. But again, that may just take more time and evaluation. I think in the primary care setting, I often feel like I have to solve everything in one brief visit, or at least give them something to take away that's going to help this problem right now. And that's not always the case. So in that case, I would try to figure out, is the sleep problem, maybe it is about anxiety. They don't want to fall asleep on their own. And so really you're doing anxiety work and helping with their sleep. But I would probably, try to focus on the sleep.
Actually, I agree with Rachel. One of the most important things I teach any age group I work with is sleep is number one. And we might use anxiety reduction or stress coping skills or, narrative practice or teaching them even at a young age to talk through why they're not falling asleep. But that then can help identify anxiety. And then from there, we actually work backwards to, is this anxiety due because you couldn't process, because you couldn't regulate, because, and again, kind of start weeding through the ADHD stuff, because in giving them tangible coping or stress reduction skills or sleep hygiene skills, we can see if they can actually complete those or not. And then that teaches us a lot about their ability to complete goals and set, complete projects.
Yeah, so I think we all agree sleep is key. Annie, a question for you, and I don't know, maybe your survey had some answers about this, but the question was whether COVID and the environmental changes resulting from the pandemic has increased anxiety and mood disorders. Did you get a sense of that from respondents to your survey?
We did. We actually separately did a series of 12 surveys that started in early days of COVID. I think our first was early April of 2020. And we surveyed our audience really regularly, every month or so, up until the 2-year mark. And what we saw was a huge spike in anxiety. And we saw this again in this most recent survey, that 2/3 of parents said that their child had, if their child was experiencing anxiety, that anxiety had significantly worsened during COVID. And interestingly, we actually didn't see the anxiety fall off very much with immunizations and opening up of schools. There just seemed to be this lingering imprint of COVID anxiety that I think persists today.
Got it. Thank you. Let's see. I know we only have 9 minutes. The time has flown by, but I want to get to as many questions as possible. This one might be a quick one for you to answer, Rachel, or maybe not, but it's how should we manage our patients on Adderall given the shortage?
Oh, good question. So we have faced shortages of ADHD medications at different times. I was practicing when we had significant issues with the generics for Concerta and couldn't get access to a lot for that. Now it's Adderall. So probably many of us have patients who have tried the other class of stimulants, have tried methylphenidate, and then are on amphetamine derivative medications and definitely do better with those than methylphenidate. If they've never tried methylphenidate, it's certainly an option to say at this point, maybe we have you try the other class of stimulant medications. If they've already shown that they don't do well with those, then having them check to see when they can get the medications that are available. And then otherwise considering non-stimulant medication is also an option. They're not as effective for some people, and can take more time to begin their effectiveness. So walking through that with patients, and if other people in the chat have had great ideas or solutions for their patients, let us know. But as far as the guidelines go and things like that, that's what we'd recommend.
Thank you. Someone had a question about whether providers consider exposure to traumatic events when determining whether or not a patient has ADHD. So how does trauma play in it? So we have 7 minutes. So if someone could give a 1-minute answer to that question so we could get to the next one, that would be awesome.
I can take this one. Absolutely, we consider trauma, but again, at the core of it is how well are you processing the trauma? Are you able to hold on to your thoughts, complete trauma-based homework assignments, therapeutic assignments? Can you complete those things? And if people are really struggling, if they say, I couldn't focus on this, I know you told me to do it. It's not that I wasn't going to do it or I was too emotional to do it, but I couldn't focus, I couldn't do this. That's when I start again looking at ADHD testing, because again, that in the moment, that focus, that working memory, that is a big indicator for me, because we want them to be able to process their trauma.
Yeah, and I think the symptoms of trauma could look like ADHD. So if a child who's experienced a traumatic event is re-experiencing the event, it was probably going to be really hard to pay attention in class. So, just like everybody has been saying, the importance of really, as Jennifer just mentioned, understanding like what is going on with the child who's not paying attention. What are they thinking about? Where are they? That might help tease out for kids who've experienced trauma, whether it's the trauma or underlying ADHD symptoms.
And I want to say something really fast that
Sure.
goes along with something Jennifer said, that they're processing the trauma and maybe they're not able to pay attention. And I really think there was a time in my practice I thought, oh, I identified this patient as ADHD. Then I found out they had trauma, and I must have been wrong. They must just have trauma. They don't have ADHD, but they can have more than one of those things. So
Yeah.
just want to say,
Yeah, that's a really good point. Let's see, one more question, and then we'll have to wrap things up. So there is a question here about bipolar, and if the question is, could somebody discuss how bipolar presents in children versus ADHD with more severe disruptive and behavioral issues? So that differential between bipolar and ADHD in a minute.
I'm happy to say briefly that the ADHD is much more common in children than bipolar disorder being very rare in children. So we would expect an episode that appears different than their normal functioning with bipolar disorder, where with ADHD, there may be some baseline impulsive behavior and irritability, difficulty falling asleep, but they're still requiring their normal amount of sleep. And then with bipolar disorder, we'd expect an episode, not part of a day, but a period of 2 weeks or so where their behavior is very different and less need for sleep and things like that.
Thank you. Well, as we are approaching the end of the hour, I want to again thank our wonderful panelists. I'm sure we could listen to them for much longer and get their insights. And I also want to thank everybody who joined today for taking your time out of your night to learn about this question of, is it ADHD? I'm going to invite each of our panelists to say their closing remarks and any recommendations for resources that folks might find helpful when they're working with kids with ADHD and other co-occurring conditions. So Annie, do you want to start?
Absolutely. Yes, thank you everyone who joined today. I would of course recommend ADDitudemag.com as a great resource. We actually have a whole channel of the website about comorbidities, and you can drill down and answer, we have several full articles about the differences between bipolar disorder and ADHD in children, for example. There's rare cases and just about every other comorbid condition that was mentioned tonight. And then I believe we will be making available an ebook of attitudes. That's the 9 most common comorbid conditions diagnosed with ADHD, and kind of an overview of each, and some comparison of symptoms, as well as like the general comorbidity rate with ADHD. And then our ADHD Awareness Month campaign continues. So if you follow ADDitude on social media or get our newsletters, you will see that we are highlighting a different condition each day for the remainder of the month.
Thank you. And we just dropped in the chat a resource list. So a lot of the things that folks are going to be mentioning now are on that list. Rachel, is there a particular resource that you'd like to highlight for everyone?
Yeah, we just highlight resources from the Reach Institute and the courses and webinars, but also the resources that we are able to share with you as you're part of the courses, and you can check out on the website.
Great, thank you. And Jennifer?
Interestingly enough, I actually recommend ADDitude all the time.
Nice.
And I actually recommend partnering with a physician who actually understands ADHD. And then also for other therapists, if people need somebody specialized or closer to them who understand executive function, again, autism spectrum, ADHD, who are well-trained, but definitely a physician who really understands it. And then, yeah, I love ADDitude. So this has been wonderful. So definitely the resources I would recommend.
Great. Well, again, thank you to all the panelists and our guests today. We appreciate your time, and do look at the resource list. As Rachel said, Reach also has resources listed on our website and offers a lot of different trainings that could be of help to you. So thanks everyone, and have a great night.
Thank you.
Bye, everybody.